Welcome everybody to the Elevate Health podcast. I'm your host, Jeffrey Rennie, and we have a special episode for you guys today about a really relatively new profession, I would say, Certified Anesthesiologist Assistants. It's something that's near and dear to my heart because a lot of my good friends are CAAs, and it's a profession that doesn't really get talked about a lot. So I am so happy to go in and inform you guys and talk to you guys about this topic. And I have no one better that can explain this than one of my very good friends, Justin Podishero. Justin, welcome to the program, brother.
Hey, thanks for having me. Appreciate it.
Just to give you guys an introduction on Justin, Justin is obviously a CAA. He works in the profession for the past, 2-3 years?
It's actually been getting to close to 4 years now.
4 years, yeah. 4 years. He's worked for 4 years, and you studied at Nova Southeastern University here in Tampa, right?
Correct.
Awesome. Is there any other type of background information you want to let the folks know at home?
Yeah, but in order to get into CAA school, you got to do your bachelor's degree. Typically like anything pre-medicine wise. So, your organic chemistry, your biology, your chemistry, your typical science pre-medication.
And we went to USF together. So
yes,
go Bulls.
Represent. Die-hard Bulls fan.
Yeah, for sure.
That's
awesome. So again, we talk about so many different professions here at the Elevate Health podcast. We've had nurses, doctors. Can you talk to me about what made you decide on being a CAA? Like, what made you pick that career path?
So, good question. I was one of the many people that was looking into going into med school, actually.
Yeah.
So I went into my undergrad school, USF, and going in, with the aspiration of going into medical school. So I did pre-med for my degree. And then about halfway through, I just figured, let me just try shadowing a couple of physicians, see, get some insight from them, what do they do when they were undergrad and so on and so forth. I did that, and some of them came up to me and says, hey, if I could do it all over again, I don't know if I want to do med school anymore. And I said, oh, why? It's a lot of politics and, obviously a lot of schooling, a lot of student debt, right?
A lot of years of school.
Yeah,
it's nuts.
So, if I could go back again, I would probably do something else. And so I was looking at my options like, oh man, if it's going to be that hard and, let me see what else I can do. So I actually first stumbled upon PA school, physician assistant school. And as I was looking at job postings, one of the first places I looked at was Moffitt, which is a cancer hospital near my hometown. And they were hiring CAAs. So I looked into CAA school, and I found out that there's a Nova Tampa that has a program, and I applied there, and the rest is history.
Yeah, man. And really, it's one of those things where it's such a new, profession. So a lot of people don't know about it. What is something that, going into it, that you wish you kind of knew about AA before getting and starting into that program?
But before going into it, I'd say my best advice is to shadow, actually. Whether that be a CAA, whether that be an anesthesiologist, or even a CRNA, a certified registered nurse anesthetist. Just shadow. It never hurts to just to see what it's like. Ask them questions. What kind of anesthesia you're doing, or how go about getting in. I'd say the best advice I can give is shadow. It doesn't hurt at all.
Yeah, for sure. And you always talk about shadowing because you don't know what a typical thing is like, and even by shadowing, you're not the one actually doing the work, but at least you get a glimpse to see, hey, is this something that you're willing to do on a day-to-day basis? And just kind of walk me through what that is like, right? Like, what is it like in a typical day for a CAA?
Okay, great. Good question. So for me specifically, I wake up around 5:30, 5:45. Hit the snooze button first.
Yeah, for sure.
And then, so when I wake up, I get to the hospital, get ready, go to the hospital. I change into the hospital OR scrubs that they provide us. Oftentimes for surgeries, they start around 7:30. So I'm usually at the hospital by 6:30, 6:45. I go straight to once I get ready, I go straight to the OR and then look up the patient, pull up the patient's chart. What kind of medications are they on? What kind of surgery are they getting? What are their comorbidities? Like, they have like asthma, obesity, hypertension, typical like health issues, right? And then draw up the medications according to that. And one of the most common medication that we use in the OR for anesthesia is propofol. That's the sleeping medication.
Isn't that the Michael Jackson drug?
Correct. Yes. So that is the drug that unfortunately killed Michael Jackson.
So you gotta be very careful with it then.
Yes, I mean, but it's in a controlled way, right? It's not like we're not just giving it willy nilly. So we know the consequences of giving too much, and then we know if we do give too much, what to do next.
Yeah, for sure. And that's with like any medication, obviously, right?
Yeah.
So it's just like there's every type of drawback. So you go in, you look at the medication, and then are you there like in surgery, like while that's happening?
Correct. Yep. Okay. So after I get all my medications ready, I get all my airway stuff. So intubate. If we are intubating, my endotracheal tube, my laryngoscope, all that stuff. I actually go to pre-op and see where see the patient. Ask them any questions like, hey, did you eat? Did you not eat anything in the morning? Because you're not supposed to have breakfast before you have surgery. Have you had any issues with anesthesia in the past? What is your social history, et cetera, right? And then once everything's all good, if there's anything specific that the anesthesiologist needs to report to me, he'll tell me then. And then from then on out, I'll bring him to the OR and then hook them up to the cables, get their heart rate, blood pressure, drip them off to sleep, and then the surgeon comes in and do the surgery.
Yeah. And then are you tested to wake them up once the surgery is done?
Correct. Yes. So for CAAs, we're there for all parts of the surgery, from the moment they fall asleep to the part of the surgery, and to waking them up and then dropping off to PACU, which is where they come to recovery. Yes, all parts.
Gotcha. And so then that's kind of like the scary part too, right? Like Albert was telling me, he was one of our first guests here talking about the struggles of being an anesthesiologist, is that anyone can put someone to sleep, but to wake them up, that kind of, so what is that process like, waking them up?
So oftentimes we'll give you muscle relaxants if it's needed. That way your muscles relax when you're getting surgery, if it's needed for the surgery. And so one of the ways you want to make sure when they are waking up is when you reverse that muscle relaxant, and that's when they're breathing normally, right? It's easier to breathe when you don't have any muscle relaxant on board. Also, when you do wake up, we want to make sure that you're awake enough to the point where you can breathe on your own. So when we take off the breathing tube, you can still breathe on your own. And there is a little bit of nuances in between there that we always try to watch out for, but making sure the anesthetic gas is all the way off, making sure you're breathing on your own, and after that, just wake you up. There's more nuances to that. I don't want to get too much to the nitty-gritty.
Yeah, 100%. This ain't like a class, right?
But yes, it's correct.
It's definitely important and a big part of the job, I'm sure. Just so for the folks at home that are on the other side, not necessarily the CAA side, but the patient side, why is it so important that you don't like eat or like whatever before surgery?
Correct. So the answer to that question is to prevent aspiration.
Oh, okay.
So what that basically means is there's a chance of you throwing up under anesthesia, and you have a higher chance of throwing up when there's food in your stomach, right?
Oh, geez.
Right. Yeah. And so when that happens is when you do throw up, there is a chance of some of that throw up can go, layman's term, it's called going down the wrong pipe.
Yeah.
So you'll throw up and then potentially it'll go into your lungs.
Yeah.
That's a whole other issue. Yeah. Correct. So that in theory is, so if you don't have breakfast, you don't have anything in your stomach, so you don't have anything to
worry about.
Up,
yeah,
right?
exactly.
Yeah. So that's why we want to prevent aspiration.
That makes sense. And like it's one of those things too, like that's like so obvious, but do people ever lie about that stuff? And like if so, like how do you like deal with it at that point?
So do they lie? We're saying this out of like to protect you, right? So it's almost like we want you to tell the truth because the only person that's gonna harm is you.
Yeah, exactly.
Now if if they lie, I mean, there's ways we'll try to get around that, right?
Yeah.
Like, we'll do what's called a rapid sequence induction. What we'll like try to push down in your throat. So if you do try to throw up, chances are it'll block it from going up too much.
Yeah, but the moral of the story is don't lie. Be
Yes,
honest
yes,
with
yes,
your
yes, yes.
people, and just like, because it's better in this case to just be honest, and like, worst thing, they move the surgery or whatever, or they just wait for it to like pass, versus like you could potentially die from the surgery, right?
Correct. Now,
Yeah.
if you can delay it, you can cancel it
Yeah.
under certain circumstances.
Yeah.
But yeah, please don't lie.
Yeah, 100%. Honesty is always the best policy, right?
Yeah. And that's us kind of enforcing that rule. It's anesthesia that pushes that.
So speaking on like, patients lying, which I'm sure is part of it, what are other challenges that you uniquely face as a CAA?
It has to do more so with politics, unfortunately.
Okay.
As you may know, in medicine, there's a lot of politics
I
involved. especially like
believe
about-
it. Oh my god.
So, being a relatively new profession, I can't say we're totally new. We've been around for several decades, actually.
Yeah. Relatively new.
Yeah. Our biggest setbacks is the politics behind it, right? So there's one profession that goes against us, and they'll do whatever it takes to make sure that they don't find us in the hospital or in the ORs or taking care of patients. It's at the end of the day, it's just competition.
I was just talking to a nurse, and nurses, I think, it can be so much with like overtime and everything like that. How is the hours and everything like for a CAA? Is it like you work as needed, or you have like a set like 9 to 5? Like, how does that work?
You can do both, actually.
Yeah.
So in the medical term, there's something called PRN, which just means like as needed.
Yeah.
And so you can put the days you want to work, and then they'll say like, hey, okay, I can use you on, for example, Monday, but I don't need you on Thursday. So you can always like adjust your
schedule
accordingly.
Yeah.
I'm your typical full-time worker, so I do 40 hours. But what's special about my situation is we get paid 40 if we work up to 40, but once we go past 40, we'll get overtime.
Oh yeah. That's
So
great, yeah.
so it's like after I go past 40 hours a week, then it's overtime, and then every hour counts as time and a half. So it's not strictly 40 hours. Whether I work 50 hours, I get paid 40, or if I work 30 hours, I get paid 40. So once I go over 40, it's always overtime. But if I work 30, then I get paid 40. So it's kind of like the best of both worlds.
100%. So you don't have to hit that 40-hour threshold, but if you do and you do more, that's like extra credit. Is it you get paid in a half, time and a half? Is that how it is?
Yeah. Oftentimes, it depends on the hospital. Mine, for instance, is a little bit more than time and a half.
Okay.
Just a little bit more.
Gotcha.
There's some places where they're just so short, you'll actually go into like double time if they're that desperate.
But I remember when we were talking before, you had your own company basically for, how does that whole thing work? Because that's an amazing type of option, I would think, for a CAA to get into.
Yeah. So I do have an LLC. I do have a little bit of I actually have a second job, and in that job I work as a travel CAA, and the best way to go about doing that for tax benefits is to open up an LLC where the hospital pays my LLC. And so I guess you're technically right. Like it is an anesthesia business. But that's not only restricted to CAAs. You can be that for any physician.
For sure.
Or even nurses. I believe nurses can do the same.
Probably too. And it's just like more ways to fill your bag. You know what I mean? And it's one of those things too. Like the more things you can do, you also like reach and network more people, and it's also not limiting yourself. Right now, we talked a lot about, the work life and everything like that, but I'm sure there's been some crazy moments that you have seen in the OR. Like, can you tell me some of those stories that you've dealt with?
So the first ever job I had coming out of school, the hospital was a trauma center. It was a few days before Christmas, and we had a pediatric trauma. It was a little girl, I think about like 9 years old. Her parents accidentally hit her with the car. Yeah, and and we came to the operating room, trying to get her to breathe. We were giving her a bunch of blood. The trauma surgeon was coming in and trying to save the patient and see where the bleeding was coming from and stuff like that. Unfortunately, the patient, we started doing CPR, trying to ventilate her and everything, and unfortunately, we just couldn't get her to come back.
Yeah.
So that's kind of like the hard part about like dealing with this profession, where it's like patients can pass away even during surgery. You just have to be ready to know what to do first when a situation like that happens. Yeah, it's
How old was the kid?
I believe it was like 8-9 years old. It was
It was a baby, man. Jeez, man. So how do you even like process that as like a person going in? This is your first job, and you see like this little kid, full life ahead of her, just like her life is gone, just like that.
The way I go about thinking is that there's a whole team there, right? The surgeon's there, we are there, the nurses are there, pharmacy, the trauma team. It's not like we were just sitting there with our arms crossed like this. It's like, okay, all right, nice. No, it's all hands on, right?
Yeah.
Like, one person's giving blood, the next person is starting chest compression, the surgeon is doing surgery, trying to figure out what to do.
You're doing everything to bring this kid back. You're not the one that caused this.
No.
You're doing your best to save her life.
And so you got to take with the situation that you're given, right?
Yeah.
So just try your best. They'll teach you in school too. Like, okay, like in a situation like this happened, what are you supposed to do? What's first? What's second? What's third? It's one thing saying it though, but it's another thing going about seeing in person.
Mm-hmm.
So after that case was done, my anesthesiologist came up to me and says, hey, like, we have a backup person that we can call, and if this is starting to be too much for you and everything, do you want me to call that backup person? If do you need a breather? Do you need some break? But we had another case going on, and I was like, well, I think I'm okay. I'll let you know. And like I said, in this situation, if I ever need to step out of the OR, I can always call my anesthesiologist, and he can do the surgery or do the case to give me a break and everything. But I mean, thankfully, I was okay.
The things that surgeons are doing to the body, like, it's insane. So the fact that like people are just like knocked out asleep throughout the entire time, like that is huge. Because if they wake up, like the amount of pain or whatever, it could cause like shock, right? Like just the effect of waking up. So it is like super important what it is that you do, right?
Oh, correct. And so that's why we're looking at all the data, like how's your breathing, how is your heart rate, how's your blood pressure. So like, obviously when you're in pain, all this stuff gets elevated, right? Like your heart rate and blood pressure, for example, and we can treat it accordingly. We can give you pain meds as needed, which is nice. Yeah.
Do you feel like there's any specific technologies? I know you've been working for a few years now. Has there been any advances, like tech-wise, in your profession where it's like, whoa, like this is like insane? Because I see it all the time in like my field, in the daycare process, like technology, especially AI, affects like everything. So I'm just curious to see if it's affecting your neck of the woods.
I mean, the in anesthesia, most of it is medications. So the newer technology can make better medications now. Right? That's so one of the newest medications that's been out there. I mean, in our anesthesia world, we know about this, but it's a drug called Sugamidex. A lot of people like it. It's basically a good reversal for your muscle relaxants, and it works instantly. And there's not a lot of side effects, but it's not super new. It's not like just came out like last year or anything like that. It's not like that. It's been there for a while, but it's been getting slowly adopted because of like patent reasons and stuff like that. But that's been the newest trend for anesthesia. And so
What about like you just mentioned a little bit on charting? Is it still like the physical, like you're writing everything down, or is it all tech charting?
Both. So some hospitals they call it's called paper charting, where you're actually writing down on a paper and pen, like vitals, for instance, and the medications you're giving. They're getting fewer and far in between. A lot of hospitals now are getting into computers and stuff like that. But there's different versions of computer software that does charting, for instance. And those are the nicer the better, because that's less stuff you have to do, and the computer will do it automatically. But no, that's been getting better. But to answer your question, there's both.
You prefer computer charting or?
Yeah, it's only because like things just automatically like your
Yeah.
vitals and blood pressure and heart rate automatically gets transferred to the charting. So that's
You know,
easy.
it's so interesting because like I just went through like this software talk with like again we work with day centers and everything like that, and one of the big things that happen now is this like hacking that happens in like hospitals. Like one phished email will go in and like affect the network, so it's just like yeah, it's super convenient, but also it's like paper, like no one's gonna be able to hack like a little paper copy, you know what I mean? Versus like if everything's online, you go and like deal with that. It's such a security concern, you know what I mean? So it's always weighing like the differences, you know what I mean? I know it's more convenient and it's easier, but also there's also that risk that like goes into it, you know what I mean?
Correct. Now, in the event of say like some kind of hacking happens in the middle of the OR, you could always revert back to paper charting.
Yeah, no,
And a lot of
100%.
hospitals will have paper charting as backup. It's just not ideal.
Yeah, 100%, 100%. Now, I know we've talked a lot about AAs and everything, but one thing that I always see when it comes to medicine is that there's a lot of misinformation out there. And what I always like to do, we do a segment on the show called Fact or Fiction.
Okay.
I'll read you something that is a common thing that's being said about your profession, and you tell me if there's fact, fiction, or a little bit of both. Maybe a little fact, a little fiction, all right? Is that okay?
That's fine.
Okay, cool. So, my first fact or fiction: CAAs are responsible for patient care only during surgery.
That is fiction.
Okay. Speak to me about it.
So it's not only during surgery. We have to do pre-op, right? So
Mhm.
we got to make sure that their labs look good, their medications look good, and also in when they wake up from surgery and we take them to PACU or recovery, how are they breathing or are they getting agitated? We can still give you medications, and so to answer your question, that's fiction.
Yeah, 100%. And it's just like, because it's a full process, right? You're not just there, okay, cool, you woke up, awesome, now I'm like leaving you. It's like, okay, is everything okay? How do you feel from the surgery and everything? Like, there's also that, because that's also very important, I'm sure, for everyone to know, like, how everything went, right?
Correct. Yep. And so sometimes we'll get the nurses that call us. Now, if we're ever busy, the nurses can also call the anesthesiologist as backup. There's multiple people that can help.
Yep. Now, the next question that I have is, the profession of CAA is relatively new.
So that's all subjective, I believe.
Yeah.
But in my opinion, I think that's I believe I'm gonna go with that's fiction.
Okay.
My profession has been around since I believe the late 1960s.
Oh wow.
Yeah.
That's 60 years now.
Yeah. So I wouldn't say it's brand new.
Yeah.
But it's not like we're from like we've been going around since like the 1800s, 1900s, early 1900s, things like that.
For sure.
It's the reason for our slow growth is mainly because like recognition. And unfortunately politics. But it's been growing at an exponential rate, to be honest, which is nice.
That is great to hear. And last thing, and CAA only monitors patients and don't administer anesthesia.
That's fiction.
Okay, for sure.
All the anesthetics that you think are given in a hospital are oftentimes I can give it too. From your propofol, morphine, from to that to blood. We can give blood to all sorts of things. Whatever we need in order for the patient to wake up well and do great. I, as a CAA, can give, not a problem.
Perfect. Now, we thank you again, Justin, for being part of the program, talking to us. There's so much in CAA that we definitely couldn't cover, but I'm so grateful for just giving us like a glimpse into your profession and how you are such an important part of the medical community. Is there one, if you could just give me just a little speak to the audience, right, about like just one thing you want people to take away from this podcast?
This one thing I should say is look into it. It's a very great profession, especially for those students who don't know that there is this profession that exists, the CAA profession. Look into shadowing, see if you can find one and answer questions for them. But my main takeaway is just give it a shot. It's such a good profession, and I'm glad that I went into this profession, and no regrets ever since I started.
Sounds good, man. And Guys, if you have any questions, please put them down in the comment section down below. Guys, really do appreciate their support. Please, if you have any questions, comment down below. Justin, thank you again for joining us at the Elevate podcast. Again, I'm your host, Jeffrey Rennie, signing out. Peace.